The diagnosis of interstitial lung disease can be quite complicated. The central diagnostic tool is a high-resolution CT scan of the chest, which sometimes in the appropriate context can give you the diagnosis, but sometimes will not. A lot of times, well, not a lot of times, actually a very small percentage of cases have to go into a surgical lung biopsy, usually a video-assisted thoracoscopic biopsy. In my practice, that may be about 10 or 15% of the cases. So typically the diagnosis is based on the history, maybe some cursory labs to rule out an underlying connective tissue disease. And then once again, everything hinges on the appearance of the high-resolution CAT scan. In order to make an accurate diagnosis, a thorough history and physical is crucial, especially the history. On the history, you want to make sure that the patient hasn't had any unusual exposures. For example, one of the conditions that can commonly cause interstitial lung disease is chronic hypersensitivity pneumonitis. Typical exposures that can predispose to this are birds, avian proteins, usually in the stool of birds, fungi, mold in the house, or from hot tubs. You can get exposure as well to various antigens that can induce a hypersensitivity response. So getting that kind of history and really delving into what the patient does in terms of hobbies and otherwise is very important. There are also certain medications that can give interstitial lung disease, chemotherapeutic agents, for example. Family history is very important, as well as risk profiling patients for possible idiopathic pulmonary fibrosis. If you look at the risk factors for IPF, male sex, older age, smoking history, and various exposures in the workplace. There are many different occupations that have an association with idiopathic pulmonary fibrosis, from woodworkers to metal workers to dentists. So it's really important to get a thorough history to develop a pre-test likelihood of if this is going to be a connective tissue disease, chronic hypersensitivity, or if the patient's risk profile is high enough that you're going to be strongly suspicious of IPF. Also, with regards to that, for connective tissue diseases in particular, it's important to rule out other systemic manifestations, and a lot of this can be gleaned from a thorough history. The physical exam is important as well. Typically, what you're going to hear on physical exam in patients with ILD and IPF in particular are biobasilar coarse inspiratory crackles, which we describe as Velcro-like in nature because it sounds like Velcro being pulled apart. It's also important to listen to the chest very carefully, certainly in the initial stages, to rule out things like COPD or asthma or chronic congestive heart failure. And examination of the chest can be very important in terms of discerning obstructive lung disease from interstitial lung disease in particular.